Thank you.
Welcome, everybody, on this beautiful fall morning to Medical Grand Rounds. It's my pleasure to introduce Dr. Forrest Arnold, who is an associate professor of medicine. He's a man that really does a lot of things. He's currently the interim chief of infectious diseases. He directs the ID fellowship program. He directs the 550 clinic. He is the hospital epidemiologist for University Hospital, and he also directs employee health, UofL Health. And a little side note, he's an avid cyclist, and on a 100-mile bike ride recently, over 10,000 feet, he tells me on the second hill, he had to stop only to help code one of the bikers that went down. And then he had to get back on his bike and finish his race. So this is somebody that can do everything. And I'm curious for us to see what co-infection and COVID-19 really means. And so I'm looking forward to your presentation.
Great. You can hear me okay?
Yes.
I tried to deviate from the topic of COVID-19 as best as I could, but I just couldn't do it. So co-infection was as far as I could venture. I don't have any conflicts, and I do want to recognize that today is Veterans Day, and that we are thankful for all of our veterans, both living and dead, and those who have served in active duty and those who have not. We're privileged here at UofL to have a VA, and so I do want to highlight one serviceman. This is Charles Garvin Jr. He served in World War II, and was a navigator in an airplane, shot down off the coast of Africa, spent a night in the ocean, was picked up the next day by some fellow servicemen. And it's good that he was, because otherwise you'd have to have somebody else do this lecture today. That's my maternal grandfather. Very happy to show you him. So let's jump into our lecture today. I'm going to go over some case reports. I started this thinking I would go over a grand rounds like Jeffrey Callan does, because his are so good. But then I got mixed into pathophysiology, and it was so exciting. I did a little section on it, and we'll go over the etiology, the frequency, and then some practical diagnosis and treatment of co-infections in COVID-19. So just to remind ourselves, viruses alone cause pneumonia. Not too often, but adenovirus does. The old coronaviruses before SARS-CoV-2, human metapneumovirus, and rhinovirus even can, although it's rare. Influenza does the most. Up to 20 or 30% of cases can cause pneumonia in some studies, and even RSV. And then for our SARS-CoV-2, I calculated a pneumonia rate of about 7%, and I got that by taking all those who are hospitalized in the U.S. and dividing it by all those reported cases, and assuming that people, if they're hospitalized, they have pneumonia, which they're probably not. So the number's probably more like 5 or 6% of SARS-CoV-2 patients develop pneumonia. So let's move on to some case reports. The first is a 57-year-old Japanese man with a history of angina and diabetes mellitus, who presented with 8 days of fever and a non-productive cough, who was admitted for pneumonia. He was 6 days before admission. The patient went to his PCP, where he had an NP swab taken for flu A, and it was positive. He was prescribed lenanamivir, which is a long-acting neuraminidase inhibitor only approved in Japan. And he was given that. His symptoms didn't improve. So 2 days before admission, he had worsening fever, went to the ER, where he had a chest x-ray that looked like this 2 days prior to admission. And then on admission, it was about the same, and he was admitted, where they did a CT scan. And now we know, because this is an early pandemic case, that this is very close to the classic picture of COVID-19 in the lungs, where you have scattered ground glass opacities, you have areas of sparing and areas of infection, and some of it can be dense, but you see a lot of this is not. So on hospital day 4, the PCR test for SARS-CoV-2 from an MP swab was obtained, and on hospital day 6, it returned positive. And this highlights some of the advances that we've made in the pandemic at this time. You see, now we've got the test down to a same-day answer. We also have COVID tests that can be done in the office or at an outpatient setting quickly. And this guy, if he had gone to the office, he might even gotten a monoclonal antibody there in the office, which would have prevented him from having to go to the ER, to the hospital. And this gentleman stayed 28 days in the hospital for this case of pneumonia. So let's go to the second case. A 57-year-old female with a history of obstructive sleep apnea on CPAP presented to the ER for evaluation of cough and shortness of breath for 4 days. Her symptoms started approximately 12 days after she returned from a trip to Jamaica. The patient initially developed a persistent dry cough and upper respiratory symptoms. She then developed shortness of breath a few days later, as well as subjective fevers. She had no GI symptoms. She went to her PCP, then the ER, where she was 92% on room air and afebrile. Nevertheless, she was put into COVID isolation, and the lung exam had wheezing. Her blood work had a white count of 6.4 with lymphocyte count of 800 and platelets of 253. The chest x-ray showed no pulmonary infiltrates. The MP swab for SARS-CoV-2 was taken. The panel was positive for human metapneumovirus, and the patient was discharged home with an albuterol inhaler and oral steroids. The positive result for SARS-CoV-2 was reported 24 hours later, which again highlights the time that we've gotten our test down to in this period. Metapneumovirus is a virus that's been around for about 15 or 20 years, and every time somebody has it, I always get asked, what is this virus? Is it a new virus? But it's been on our panel in the hospital for about 10 years, and we do see it at times. And this particular patient had both SARS-CoV-2 and metapneumovirus, two viruses. So let's talk about distinguishing between a virus and a bacteria, because when we think of co-infection, we can also have bacteria. So we get different markers in the lab to help us delineate, okay, is it a virus, is it a bacteria? And this is called a ROC curve. So you have the sensitivity plotted against 1 minus the specificity. So if the diagonal line here that's labeled, I labeled equivocal, is means there's no association. So you could look at the color of a patient's socks and determine whether they have virus or bacteria and plot it out, and you would get that 45-degree angle. So as the closer you get to the upper left-hand corner, the better the test. And there's probably no best test, but at least that's the ideal test, would be one that shoots right up there and tucks into the corner. The best tests that we have practically are the ones that I labeled better there. Anyway, you see from this curve that white blood cell count is not much better than looking at the color of the patient's socks. The neutrophils kind of add to that, and then we have C-reactive protein, which is pushing up to the upper left-hand corner, and procalcitonin. So when you look back at the influenza pandemic 1918-19, they did autopsies on everybody, and they tried to see who had a co-infection and what did they die from, because most of the people who had flu actually died from bacterial pneumonia. So you see that the one that was the most out of these, well, these are labeled all military, all civilian, and then they combined them, and then they put all higher quality military and civilian as if there's a bunch of VIPs, but that's relating to the quality of the specimen, not the quality of the individual. This is not a judgment of character. It's a judgment of their autopsy specimen, because this study was done just a few years ago, 2008. Anyway, out of about 3,000 samples, most of the people had strep pneumo. Well, most of the people who had a co-infection had strep pneumo, 23%. And then you see the other pathogens there: Streptococcus hemolyticus, Staph aureus, Diplococcus intracellulare meningitis, that's Neisseria meningitis, mixed pathogens, Bacillus influenzae is Haemophilus influenzae, and then other bacteria. So this looks at lung tissue, and then they took the same individuals and looked at their blood and their pleural fluid or empyema culture, and that showed the same thing, that strep pneumo was high, but strep hemolyticus was even higher, and then Staph aureus and the rest. And in a sense, well, let me do the next case, and I'll do this first. A 58-year-old male with a history of pulmonary tuberculosis over 2 decades ago was brought to the emergency department complaining of less than a week's history of chest pain. The pain was sharp, pleuritic in nature, left-sided, and associated with myalgia, intermittent fevers, chills, and productive coughs. So this presentation is a little different than the previous two. The patient also endorsed exposure to SARS-CoV-2. On presentation, the patient was normotensive, tachycardic, with oxygen saturations about 95% and a temperature 99. He was on low flow oxygen and no respiratory distress. He had crackles in the left upper lung fields extending to the mid lung field, and this was his chest x-ray. I apologize for the arrow. I didn't put that on. The person who published the article did. I know you can tell that there's an infiltrate on the left side there. They also had a CT scan, and the authors added these arrows too. So what you're seeing is a combination of ground glass opacities with a dense left-sided infiltrate. On the right picture, the upper arrow points to that. So his white blood cell count was 10.3 with 93% segmented neutrophils. An MP swab for flu A and B was negative. A pneumococcal urinary antigen test was positive. Ultimately, an MP swab for SARS-CoV-2 was positive. So what I want you to get from this is that this patient had coronavirus plus strep pneumo. And when you add those two together, you get poor outcomes. I tend to be a little mathematical, so I made this equation. Virus plus strep pneumo is bad. It's also simple. I kind of wish this lecture was next week, because just yesterday we went to the ER to see a patient who had coronavirus last month, and then now he's in the ER with a huge empyema. It's got gas bubbles in it. It's dense. I'm just sure it's going to be Clostridium perfringens, but he'll get his chest tube and his culture, and we'll see. Maybe there will be an update. I sense that next time I'm going to do another coronavirus grand rounds. Anyway, let's look at some studies here. In this study, they took mice and they injected them with, or exposed them to, either pneumococcus or influenza or saline, one of the three, and then a week later gave them something else. So when they gave them saline and a week later gave them pneumococcus, then most of the mice lived, about 80%. If they gave them saline and then influenza, well, it killed off even more. It's about 60% of the mice lived. And if you gave them saline and then pneumococcus with the flu, about half of them died. So they did a couple more experiments. If you gave them pneumococcus and then flu, they all lived. That makes no sense, but that's why we do scientific experiments, right? So they gave these mice pneumococcus. A week later gave them flu, and then they had no deaths for the next 3 weeks. But if they flipped that, gave them flu first, and then pneumococcus, oh, I got that labeled wrong, but this is flu, then pneumococcus, they all died. So then they played with this variability. So if you look at this, we have survival on the left. And so if these people got pneumococcus on the far left and then flu, so we already know what happens to those people when they got pneumococcus and then flu. They all live. If you give them to them both at the same time, we already know what happens there. About half of the mice died. But if you give flu and then a week later give pneumococcus, they all died. And then if you wait longer to give your pneumococcus from influenza, then the mortality improves. So what this tells you is if you get flu and then you get pneumococcus within a week and you're a mouse, you're dead. So let's look at the lungs of these mice. Here are mice that were infected with pneumococcus only, and they did not vary from the controls who were not infected at all, which is amazing. We think of pneumococcus as being so severe and having a high mortality that it would do some kind of long-term damage, but in these mice there was no damage between the controls and pneumococcus. Now for the mice who were infected with influenza only, there were multiple parenchymal foci with alveolar inflammation, alveolar epithelial cell hypertrophy and hyperplasia, and occasional alveolar necrosis with fibrin deposition. Inflammatory cell infiltrates with lymphocytes, neutrophils, and macrophages were seen, particularly if you look around the blood vessels. And then if we have infected with influenza, then 1 week later infected with pneumococcus, these are the mice that died. They had changes more extensive than either of the two mice above. They were extensive in severe consolidation of affected lobes and obliteration of alveolar architecture, which were striking. Inflammatory infiltrates, epithelial cell hypertrophy, and hyperplasia and fiber deposition were common. So who gets pneumococcus after having the flu? Well, we could extrapolate that question and say, well, how does that correlate to people with coronavirus? And what they looked at were, on the left side, we see people who did not have COVID-19, and on the right, patients that did. And the patients that had COVID-19, they were more colonized with strep pneumo. And these were people where it was actually just colonized and not causing disease. So everybody on the left had COVID. Everybody on the left did not have COVID. On the right did have COVID. And the people who had COVID were more colonized with strep pneumo. Then they looked at healthcare workers. And we have a batch of healthcare workers who did not have COVID-19. On the left, they were colonized 12%. The healthcare workers that were COVID-19 positive were colonized almost 35% of the time. And now is when we're online and we don't have the benefit of being in the auditorium, because I'm just sure Dr. Barbie, if I asked why is this the case, he'd be jumping up and down and waving his arm. He knows. And he's right. Here's an example of where flu, and you could extrapolate to SARS-CoV-2, you get pneumonia, it affects your lung, and that goes on to affect your gut. Your gut microbiome is changed, and these people become colonized with pathogens. And this may be why, if you get the virus first, it's followed by the bacterial pneumonia so much more. Now, I don't want you to leave and think that if you get flu or your patient does, and a week later they get pneumococcus, they're definitely going to die, because they're not a mouse. So I have 3 case reports here of people who had just that. And the first was discharged home without oxygen. The second one was discharged home with 5 days of doxycycline. And the third was discharged home with oral penicillin. So positive stories from real cases, and it's not so absolute. So let's look at our pathophysiology just a bit more. There's some damage to respiratory epithelium, and what we see there is that you have your epithelial cells with the cilia, and then you begin to have bacteria adheres to the cells. So then this goes on, there's an antagonization of interferon responses that enhance bacteria adhesion, colonization, growth, and then invasion into the healthy sites. So you see that the adhesion goes to colonization, and the colonization goes to growth, and eventually you get pneumonia. So this affects both the innate and adaptive immunity. So here's a cartoon where you see that both the innate and adaptive immunities engaged when somebody has infection. On the left side is where you see this dendritic cell right in the center will actually reach through the epithelial cells and get in contact with the antigens in the middle of the picture. I don't know if you can see my mouse. Just like Plastigirl reaching between those cells and exposing. And so then the dendritic cell can further go on and identify as an antigen-presenting cell the other cells of the cell-mediated immunity, and then eventually adaptive immunity with the T and B cells. So if you think that you just saw an incredible, you did. Let's move on to the co-infection etiology. There's been a number of pathogens in some studies and reviews that have tried to keep track of which bugs are associated with co-infections. And you see it's a variety of bacteria, viruses, and even fungi. So at this point, I want to make a distinguish, and the literature does not make this very well, especially the literature further back in the pandemic did not do this. Sometimes they use the word co-infection, and sometimes you use the word superinfection, or they say co-infection and they mean superinfection. That's usually the case. So a co-infection is where you have COVID-19 plus, some other pathogen and the patient presents. But a superinfection is when you have COVID-19, then you get another infection. And we see a lot of this in the hospital because people will come with COVID-19 and then 1, 2, 3 weeks later get infected with another pathogen. So if we look back at the table I just showed, I tried to label some of the co-infection and superinfection pathogens. So the co-infection are community acquired, essentially Klebsiella, Staph, Strep. You think of your viruses and then Aspergillus. But if you come to the hospital and you have a hospital-acquired infection, that's why Acinetobacter is on this list, Pseudomonas, and Candida species. So when you see studies that have figures like this, you'll see a mix of them. And if they've gone to the trouble of teasing out which ones were co-infections and superinfections, it really should probably be two different tables. But here we see Mycoplasma right next to Pseudomonas, right next to H flu. So you've got community-acquired bug, hospital-acquired bug, back to community-acquired bug, then Klebsiella, which could probably be a little bit of both, and so on. The viruses are the same way. Most of the viruses are co-infections because that's where we get exposed, but it's possible to get something if the patient doesn't get in isolation soon enough, or if a visitor has the virus and they come visit the patient a week or two later and give it. We occasionally see that, and it's really a tragedy. Anyway, let's talk about how frequently this occurs. And there have been a number of meta-analyses, and I don't want you to read all that. I just want you to appreciate how many case series are out there. And so this co-infection rate, I've enlarged the bottom of the table to show that overall it says about 20%. But I also want you to notice that there are several studies up there that are pegged all the way to the right, which means 100% of the patients had a co-infection, which tells you it's really just a case series where they looked at patients with co-infection. I'm not sure why they included it in this meta-analysis, frankly, because you know that not everybody who has SARS-CoV-2 has a co-infection. They also looked at superinfection rate, which was even higher, and this makes sense because the longer you're in a hospital, eventually you're going to come down with something. Again, there are studies in this meta-analysis that are pegged over to 100% co-infection. Again, I think they should have weeded those out, and they would have gotten a value a bit lower. So you'll notice in this final meta-analysis, it gives a value of about 7%, and there's no studies that are 100% co-infection. So that's kind of what they did with this one. They went through and tried to really bear down and see which authors were defining co-infection as truly an infection that happens at the same time with another infection. So let's look at the diagnosis and treatment for a moment. There is a decision we have to make when we have somebody with COVID-19. A lot of times if people have COVID-19 and that's all they have, and that makes us tend to just want to wash our hands and say, okay, we have a diagnosis, we're done. But we need to have some thought that perhaps they have a co-infection, and then there's a benefit of giving antibiotics because if they actually do, then their outcomes will be improved. But there's also a risk of antibiotics because you'll increase antimicrobial resistance, and you'll cause perhaps superinfections with C. diff or something. So you want to get that happy medium. So when we work up for co-infections, we want to go ahead and get those tests, and you can check a number of things. And I'm just going to review this to let people know what's available. Not that everybody should get all these tests, but of course, there's your regular sputum gram stain and culture, and you can get a fungal smear and culture, AFB stain and culture. The few people that we have who have tuberculosis surprise us, and that's why we isolate people at university. We have these about every 3 months, and it's so great as the director of employee health to be able to say the patient was in isolation. We don't need to go screen 25 employees to see if they've gotten exposed to tuberculosis. There's an atypical pneumonia panel, and this is a throat swab. We actually do it at our ID reference lab, and you can order it, and it checks for different pathogens. The thing it has on it that is not anywhere else is a PCR for Legionella. And the test underneath here, says urine Legionella antigen, and that checks for serogroup 1, but the PCR from the throat swab checks for multiple serogroups, which can cause Legionella. So serogroup 1 causes most of them, but if it happens to be a different serogroup, we might pick it up. The reason this is not on a commercial test is because it's not FDA approved. So there's also a urine strep pneumonia antigen that is useful. There's a viral respiratory panel, which we've renamed respiratory pathogen panel because they've added bacteria to the viral panel. That would be for chlamydia and mycoplasma, so kind of rounds out the atypical causing bacteria there. So if you have somebody you suspect has a co-infection, you want to start empiric antibiotics and then de-escalate them as this stuff comes back negative. The fungal tests are in the upper right-hand corner there with your 1,3-beta-D-glucan, galactomannan assay, urine histoplasma antigen, and a serum cryptococcal antigen. So when we look at what we should cover and when, this was published, and it's basically expert opinion, but they are experts. They say the bacterial pathogens that colonize the upper airway in somebody with COVID-19 are the same range. So you're expecting strep pneumo, H flu, chlamydia, staph aureus. And so they say if you're going to start antibiotics, you're going to use the same antibiotics that we use for community-acquired pneumonia that are in the guidelines. So on the floor, we use a beta-lactam plus a macrolide, or you can use a fluoroquinolone like levofloxacin. In the hospital, we tend to shy away from the empiric levofloxacin only because it partially covers tuberculosis, and then your AFB tests are delayed, and so that's not good if somebody actually has tuberculosis. So we like to establish a diagnosis, and of course if somebody ends up having TB, to give them the TB therapy of choice. So if somebody's high risk, which basically means they're in the ICU, you can again give them a beta-lactam plus a macrolide or a beta-lactam plus a fluoroquinolone. So these are the same recommendations with CAP and with COVID-19. So who does get antibiotics? They looked at the procalcitonin. Remember, I showed you that in the beginning, where the closer to the upper left-hand corner it was, the better. And they looked at 339 patients, and of those who survived of their co-infection, they had a low procalcitonin of only 0.06, and then the people who died had a higher one of 0.22. Now, they say their normal is less than 0.1. That's really low, and maybe they did that for this study, or they just picked a number in between this 0.06 and 0.22, because the regular normal, like if you look in our hospital and click on the normal values of procalcitonin, it's less than 0.5, and everybody's less than 0.5 in this study. You see that this was statistically significant, but when they added it to the multivariate analysis, it wasn't. And what was significant were these next four things: dyspnea, cardiovascular disease, acute respiratory distress syndrome, and lymphocytopenia. If the patient has ARDS, it was very associated with a bacterial co-infection, and the hazard ratio was 29 times. So let's look at another study. This one's larger with 1,700 patients who had COVID, and they looked at people. 57% of them got treatment for co-infection, and 43% didn't. So that's 965 people out of the 1,705 patients got treatment for co-infection. So you got to figure that's a little bit of over-treatment, maybe a lot of bit of over-treatment in an effort to get everybody who had a co-infection. But just to highlight how not very good we are at estimating this, there were 59 patients who had co-infection, only 3.6% of the people, and they missed 12 after giving 54% of the people antibiotics who did not need them. They still didn't get the 59 people who had all of them an antibiotic. So that's why this is so hard to estimate just based on clinical judgment. So when they did a multivariate analysis, they found that people who had co-infection were older, 72 versus 64 years. They had a lower BMI, 26 versus 30, and they were severe. And I put their definition of severe because I know the ICU docs would want to know exactly what that means. So you can see that there. They also, these people had a lobar infiltrate, which is kind of classic for strep pneumo. And interestingly enough, they found that people in for-profit hospitals got antibiotics treatment for co-infection more than the other. And here's all the hospitals plotted out. The ones with the arrows are the hospitals that are for-profit, and then not-for-profit are all the others. So you see that they're kind of to the right, and on the right are the amount of antibiotics. The hatched and the blue lines and the clear, that's just the type of antibiotics they got. But as you can see, the farther to the right, the more antibiotics, and the arrows are all kind of to the right for the for-profit hospital. I'm not going to draw a conclusion why, but maybe you can come up with one. Anyway, it's difficult to determine if somebody has a virus or a bacteria. So let's again entertain this in a 2x2 table. So if you look at this, you can say we're going to have a test of procalcitonin, and then above is the absolute truth, whether or not they have a co-infection or not. And in this study of the 1,705 people, this is how the numbers played out. 19 people had a positive procalcitonin and actually had a co-infection, while 186 people also had a positive procalcitonin, but they didn't, so that was a false positive. Then there were 690 true negatives, and then 13 people had a negative procalcitonin, but they actually had a co-infection. So you can get the sensitivity and specificity from this, and that's when you do your numbers vertically with the calculations there. And the sensitivity was only 56%. The specificity, only 79%. The positive predictive value goes to the right here, 9%. The negative predictive value is what's good here. So basically that means if you have a negative procalcitonin, then you pretty much don't have a bacteria. That's great, but the question is, okay, what about the people who have a negative procalcitonin but actually have co-infection? That's what we're worried about. And so that's why I want to say you can't boil down the decision of starting treatment for a co-infection to just a number like a procalcitonin. You have to use an assessment made up of history, physical exam, imaging, lab work, and all together. So today I want to review that we have seen COVID-19 that may be associated with a co-infection. We didn't used to know that the two could come together. Co-infections with COVID-19 do not occur commonly as we once thought. It's less so because a lot are superinfections. Think of co-infections, though, especially if patients are not responding. Some co-infections are technically superinfections that are hospital acquired, so we want to prevent and treat early in those patients and try to keep those patients from getting infected once they're here. And procalcitonin is a tool meant to supplement our history and physical and radiology, not replace. And with that, I'm going to take questions from anyone.
Awesome, Dr.
Hey,
Dr. Arnold, thank you so much. We've got a little bit of time, plenty of time here, guys. So anybody, if you want to ask anything, you can unmute your mic and ask, or if
yes.
you wanted to type it in the chat area, we can see it there. So,
Hello. Hi, this is Aldas from Infectious Disease. I'm second year fellow. I have a question to Dr. Arnold. Dr. Arnold, is there a cutoff, maybe by hours or by days, of how many days we need until we say this is a co-infection? And if we pass that cutoff, maybe we can say this is a superinfection now. Is there like something like this?
There is, and you all should know Aldas is doing research in co-infection, so he has a good question. For community-acquired pneumonia to hospital-acquired pneumonia, the cutoff is 72 hours in the hospital. So if you have pneumonia defined within the 72 hours, it's community-acquired, and after is hospital-acquired. That's kind of an arbitrary time, but it's generally true, and the CMS uses that to say whether or not somebody has had a complication in the hospital or not. And so the same applies here with that 72 hours. They didn't come up with a different time range, which is good. It's not one more thing to memorize.
Thank you.
Thank you.
Dr. Arnold, this is Robert Emmons. How much are your comments modified in the immunocompromised setting? Are any of these things that you've stated different, or is everything in terms of the parameters, the times, and the definitions the same?
There is a whole group of people who have what's called pneumonia in the immunocompromised patient. And the data is thin, but we did just publish in Chest pretty extensive article about what the pathogens could be and the treatment approach, because the treatment oftentimes will be a little broader than your non-immunocompromised patient, and you might start an antifungal sooner. And we tried to tease out what immunocompromised means. So different populations, this person is on a drug, this person has a disease, that kind of thing. And so I would direct you there, and I'd be happy to email that to you to give you a little more direction. It's because, when people are enrolled in a pneumonia study, if you're immunosuppressed, you're excluded. Just like if you're pregnant, you're excluded. So what should we really give a pregnant patient or an immunosuppressed patient? We have to extrapolate from somebody who has a normal immune system, and that doesn't seem right. So that's why we got together. And one of the purposes of this article was to stimulate research and have people actually do studies in the immunocompromised with pneumonia so that we could begin to get data. It was kind of a call for data, basically, and to show people what the questions are, and just like you have. So, for now, it's mostly for immunocompetent people today, and then I can make that article available, or maybe Jason, I can give it to you to distribute as well. I think is very helpful for that special population.
yeah, definitely.
Thank you very much.
Good to hear you.
Real quick, I know Dr. Krieger she's waiting patiently, but Dr. Dryden had a question in the chat area asking, is this an artifact of the multiple testing modalities that we are now employing?
Some of them are. There were some studies where they're searching for co-infections, and of course, the more you're going to look, the more you're going to find. The thing that showed me that the most as a fellow was when we had the anthrax we were going through, and so all of a sudden everybody was checking for anthrax, and what do you know, you're finding it. So you find 10 cases of anthrax of people who are colonized or whatever, or skin lesions, and nobody checked before, and they didn't know, and people got over it with other means. So yes, some of this is a little bit a result of checking a lot. And so I think that article where I showed the healthcare workers and patients who were colonized with strep pneumo, those were not causing infection. Those were just people colonized with strep pneumo, which is a predisposition for developing strep pneumonia, but it wasn't actually causing infection at the time.
Excellent. Go ahead, Dr. Krieger.
Yeah, so Forrest, I'm going to ask a nutrition question, at least in your hospitalized patients. Are they following correlations in particularly superinfection patients with their nutritional status? Any markers of nutritional status or vitamin D levels I'm going to mention all the time?
Yeah, you mean they being us keeping track of pneumonia people? And no, but it's a good point because I think I'm just getting started interacting with Dr. Barbie and the gut microbiome, but I think there's a lot there. And we're going to find that the nutrition correlates incredibly with infection. And not only that, the people who are using their bowel, the people who have TPN are probably in the worst condition to protect themselves. Yep. Because we think of the intestines actually as an extension of the immune system. So it's a good point. We should begin to think what markers should we keep track of nutrition in our patients with pneumonia.
Great.
All right, and just real quick, Jessica Petrie from over at the Kornhauser Library, she has posted links to the things that Dr. Arnold was mentioning. They're in the chat area if you folks want to take a look at those or copy those links. Also, again, so if anybody had any more questions or anything, again, you can type it in the chat area or unmute and ask. Where Dr. Arnold covered the bases in such an excellent way that there's not much left to ask. Actually, okay, here we go from things from your guys down at Med Center 1, Dr. Arnold. A question from Sharanya from ID Research. In case of structural lung diseases like bronchiectasis, yes, who are colonized with pseudomonas, do we consider it as a co-infection?
It would depend on the study. So if they were, this kind of goes back to Dr. Dryden's question, because if they check and they're keeping track of what's in there, then yeah, it would go down as a co-infection. But clinically, if you're a doctor in the hospital, you're looking for causes of pneumonia. You'd prefer to have, for example, a bronchoscopy of somebody with a deep specimen than just coughing up, because you know that they're colonized with Pseudomonas likely in their bronchus, and so some discernment in the way the studies are performed needs to be considered when you actually take care of patients. Thank you.
All right. Anything else? Just like I said, we still got plenty of time. So if anybody has anything, please feel free.
I might just add that one of the studies there said that they had a co-infection, that there were more co-infection for people on the floor than the ICU. And I think that was because the people who were admitted to the floor had been there a bit longer and had more time to get a superinfection, not really a co-infection.
Forrest, I did have one other question, because you on the studies that you gave about antibiotic use, antibiotic choice, empiric or not, and then who actually had a superinfection or co-infection. Did the same article then give any outcome, and was the power significant enough that you could see that the outcomes were different? In other words, did you have were dramatically reduced outcome if you didn't get antibiotics, or did the giving of antibiotics dramatically increase nosocomial infection, like you mentioned? I mean, what can we conclude about that, since since the algorithm that you showed us comes up with, it's still clinical judgment, it's not procalcitonin, it's a bunch of these other things, and we want to get it right. So what do we do for a practical matter?
Yeah, and they didn't give outcomes based on individuals, but you got to figure the few individuals who didn't get antibiotics who actually had a co-infection did worse. But then the question is, did they? So that's a good question. And that's worth actually emailing the authors. So I'll just make that point too to the I still consider myself a junior faculty, but I guess I just have to break down and admit I'm not. Anyway, when you read an article, there's always a corresponding author. And so that's the opportunity, if you have a question, to email the person and say, hey, what about these 9 people who didn't get antibiotics and did have a co-infection? Did they all live or all die, or what's the deal? And a lot of times they'll answer, and it's a nice way to collaborate with people at other universities and around the world. I think I might do that.
Let us know, and let us know about your patient, whether they have Clostridia. You think so?
Yeah,
because of the
okay.
bubbles?
Yes, that's exciting. I mean, I hate to get excited at his expense, but that's what it is. So.
Okay. Well, thanks for a wonderful and thought-provoking presentation. I think the reason we're sitting here is we're all thinking about studies that we need to do to answer some of these very important questions. And I think we're also very happy that we're not mice that got influenza and then got pneumococcus.
Yes.
Yeah.
Thank you very much. I appreciate it. Appreciate
Yeah.
the opportunity.
Thanks, everybody. Have a great week. And thanks, Forrest.
Yes.